to the next talk of the session by Dr. Siddharth A Kakodkar, which is cryoablation for atrial fibrillation, an option beyond drugs. Dr. Siddharth Kakodkar is a cardiology specialist in Aurora, Illinois, and is affiliated with Amita Health Mercy Medical Center, Aurora. Dr. Kakodkar has over 17 years of experience in the medical field. He graduated from University of Illinois College of Medicine, Chicago Medical School in 2004 and subsequently completed his residency from Brown University. He went on to pursue his fellowship in clinical cardiac electrophysiology from Rush University Hospital, Chicago. His clinical interests are AFib ablation, cardiac electrophysiology, CRT device implantation, pacemaker, loop recorder implantation, subcutaneous ICD implantation, and SVT ablation. Over to you, Dr. Siddharth Kakodkar.
All right. Thank you very much. Let's see. All right, so thanks for inviting me. So far, all the talks have been great. I was asked to talk about cryoablation as first-line treatment option for atrial fibrillation. And the reason this comes up is because, there's been a lot of change as far as how we do an AFib ablation over the last 10 years. It used to be, a very variable procedure. It could take between 2 to 6 hours to do PVI with radio frequency ablation. And now with cryoablation, doing pulmonary vein isolation is a very easy procedure and a very predictable time slot for the procedure. Usually 2 hours is all that's dedicated to do this, the full PVI with cryoablation. And because of that ease, I think it's been more acceptable over time to offer ablation as first-line therapy for AFib rather than, trying years of medical management that we all know doesn't work very well. So I like to start the talk with a patient presentation. 58-year-old male presents to an urgent care facility with increasing fatigue and dyspnea on exertion over the last few weeks. He denies chest pain, palpitations, or lightheadedness. And he has no previous medical history. And physical exam, he's overweight, and he has an irregular heartbeat and mild lower extremity edema. Here's his EKG, clearly showing atrial fibrillation with rapid ventricular response. So this is a new diagnosis of atrial fibrillation. And if this is seen in an urgent care or primary care's office, they are always figuring out what to do next. And our initial lecture today went over, the basic management strategies for AFib. First thing is to consider their stroke risk and start the appropriate blood thinner. My recommendation is just start the blood thinner, because even if they have a low CHA2DS2-VASc score of 0 or 1, you might end up cardioverting them. You might as well start the blood thinner now and then decide later what to do after they're in normal rhythm. There's rate control medications, beta blockers, calcium channel blockers, and then we recommend urgent consultation to either EP or general cardiology. And while all that's happening, consider the risk factor modifications, sleep study, echo, stress test, weight loss regimen, etc. And we went over the CHA2DS2-VASc score, but there are limits to the CHA2DS2-VASc score. It doesn't really take into account sleep apnea, the level of their diabetes, progression of their disease process. So the next steps, this patient underwent immediate TEE cardioversion by general cardiology. And after that, the question is, what do you do? Do you start an antiarrhythmic drug, such as flecainide or amiodarone, or do you schedule ablation therapy? So the need for AF treatment has grown. It's a large growing population of patients all over the world. They estimate 33 million patients have atrial fibrillation, but I wouldn't be surprised if that's grossly underestimating the actual prevalence. At least in the United States, the AF volume of patients will double by 2035. And a lot of these patients, greater than 60%, have arrhythmia-related symptoms. And 31% of the patients with AF will have greater than or equal to one hospitalization per year for atrial fibrillation. In my practice, the majority of patients that I see in clinic are for atrial fibrillation. And that just might be the patient population in the United States. Unless there are contraindications, ablation therapy is offered as a viable initial option to treat atrial fibrillation. And I'll go over the recent data and guidelines that do support this practice. Other options include medical management with rate versus rhythm control, but we know that these are less effective options. And with newer technology, such as cryoballoon, ablation is very safe and relatively quick procedure. And then, of course, ablation is not the only aspect of the treatment. We also undergo risk factor modification. Now, this is an important slide because this kind of shows why the sooner you go for ablation, the increase in overall success rate. So we know that as patients over time, as they get older, they start off with their genetic predisposition for AFib, whether they have a family history and they're having atrial fibrillation at a very young age. Usually 30s would be the younger age group side of it. Then over time, you have age and disease-related remodeling of your left atrium. And what's key is once you start having atrial fibrillation, that tends to beget more AFib, because while in AFib, you develop fibrosis of the left atrial tissue, which can lead to other triggers or rotors within the substrate, making your normal pulmonary vein isolation procedure inadequate, because now you've developed other trigger points in the left atrium. And so over time, as you have paroxysmal AFib, we see it present or lead to persistent atrial fibrillation and eventually permanent atrial fibrillation. And as EPs, we love doing ablations when it's a newer diagnosis of paroxysmal AFib. We know that pulmonary vein isolation has a much higher success rate of working. Once you get to persistent AFib, doing PVI, you find a higher rate of recurrence. Then the holy grail is, what do you do for these patients with additional ablation? And everyone now is coming up with their own strategies for ablation beyond the initial PVI, and there's really no accepted method once it gets to that point. And there are consequences of progression of AFib beyond the success rate of the procedure. You have decreased quality of life. They're important to look at it because in the past, we've always thought that, whether you're persistent or paroxysmal AF, that you pretty much are treated the same. There's really no difference. But we know that there is a 20% higher risk of stroke or systemic embolism in persistent AFib versus paroxysmal. There is a 28% higher risk of death in patients with persistent or permanent AFib compared to paroxysmal. There's double the prevalence of heart failure with persistent versus paroxysmal, possibly lost due to the loss of atrial contractility and losing that cardiac output. You have increased hospitalizations as well as increased prevalence of stroke. So the importance of early catheter ablation is shown from this study from 2019, looking at the shorter diagnosis to ablation time, or DAT as they listed here. And it was associated with lower arrhythmia recurrence and reduced cardiovascular hospitalization. So that's very important. We all kind of know this because we know our success rates depend on early intervention, but it's nice to have data here showing that, the sooner you get this patient to an ablation procedure, the increase in success rate as far as being arrhythmia free and avoiding hospitalization. There are multiple guidelines that have come out from different societies that have all basically said that it is reasonable to offer catheter ablation as first-line therapy rather than having them go through the antiarrhythmic drug trial phase with greater than 50% chance of failure. So in 2014, the AHA-ACC heart rhythm guidelines said that it's reasonable to offer ablation as an initial strategy. In 2017, heart rhythm, as well as these other societies, also said it's reasonable to try catheter ablation prior to initiating antiarrhythmic drugs. And then in 2020, same thing, it's reasonable to offer it. 3 trials came out early this year in January and March. The early AF trial, Stop AF First and Cryo First, all looking at specifically cryoballoon ablation as a first-line therapy for AFib. And you'll see that the main differences between the 3 trials, the early AF trial was the most inclusive as far as the patient population, and then Cryo First was probably the most stringent of the 3 studies as far as what patients were allowed for their selection process. And you'll see that regardless of how stringent the selection process was, the results were pretty much the same as far as safety and efficacy. So Stop AF First was one of the trials that came out in January that gave that led to the FDA approval of using cryoballoon or cryoablation for paroxysmal and persistent atrial fibrillation ablation. So let me move on. So comparing the 3 trials, I mentioned the inclusion criteria. Early AF trial all the way on the right was basically 18-year-olds or higher and non-permanent AFib, and that was pretty much it. Stop AF was a slightly more stringent, 18 to 80 years of age, but symptomatic paroxysmal atrial fibrillation was allowed, and so that means no persistent atrial fibrillation. And then Cryo First had a smaller age range, 18 to 75, again, symptomatic paroxysmal AFib, but also they wanted essentially structurally normal hearts and normal EKGs at baseline. So there are also major exclusion criteria. Early AF, the main differences were that they allowed EF greater than 35%, so they excluded less than 35%. In Stop AF, they excluded EF less than 45%, and Cryo First less than 50% because they wanted structurally normal hearts. Also in early AF, they allowed larger left atrial diameter sizes. And in my opinion, this represented the normal patient population, this early AF trial. These are the patients that I see come through the door more than anything else. But Cryo First took into account those other factors that could decrease, procedure success rate and try to bring in more structurally normal hearts to look at that. And overall, you can see that there wasn't huge differences other than, let's see, congestive heart failure percentage was higher in the early AF trial based on their exclusion criteria. Also good to know is that flecainide was the most common used antiarrhythmic drug in all 3 trials. The primary efficacy results are all shown here, and you can see that cryoablation was superior to antiarrhythmic drug therapy for the prevention of atrial arrhythmias, and this is over a 12-month period. You might also notice that the actual success rate between the 3 studies does vary significantly, where you see Cryo First has a success rate of 82% versus early AF is down to 57%. And a few reasons for that. As I mentioned before, early AF trial had a very low exclusion criteria, so they included a lot of heart failure patients with large left atriums versus Cryo First, which had structurally normal hearts. Also, the way that these patients were monitored in the 3 different trials were very different. Early AF involved using a loop recorder, versus Cryo first use the 7-day Holter monitors every 3 months. So it's possible with closer monitoring, they may have caught more atrial fibrillation after ablation in the early AF trial. Very importantly is that patients in the cryo balloon arm versus the antiarrhythmic drug arm were asymptomatic at either 12 months or post-blanking. So people felt better with ablation, and there was improvements in AF-specific quality of life in the ablation arm versus the antiarrhythmic drug arm in all 3 trials. And very interestingly is that there was no difference in time to the first significant adverse event between the ablation versus drug arms in all 3 trials. In fact, the early AF trial even saw a slightly higher percent of significant adverse event or complication compared to cryoballoon. That's very interesting because the procedure you would assume would have a higher event rate compared to medications, but that didn't show in all 3 trials. So there was actually a lower proportion of subjects in the ablation arm who experienced any adverse event despite ablation being an invasive procedure. All 3 studies observed low rates of serious procedure-related complications in patients in randomized to the cryoballoon arm. As you can see, there was no atrial fistulas, deaths, strokes. We did not see, in my practice, we've never seen pulmonary vein stenosis after a cryoballoon. And that probably has to do with the shape of the catheter and not really getting inside the vein to cause that kind of damage. 1% of patients had a clinically relevant pericardial effusion that likely required pericardiocentesis. There was a 1.9% persistent phrenic nerve involvement. Just a quick few slides on the actual cryoballoon system. These are all the parts of the console right here. This is the main console. This is what the catheter looks like. It also involves what's called a FlexCath Advanced Steerable Sheath. And there's an Achieve mapping catheter that goes inside the lumen of the ablation catheter so we can actually map pulmonary vein potentials real time while you're freezing and isolating the vein. So this is another picture of all of that. So there is a nitrogen gas tank that will sit inside the cryoballoon console, and liquid nitrogen is delivered to the balloon, and inside the balloon, the nitrogen vaporizes or nitric oxide vaporizes and absorbs the heat and essentially freezes the tissue. It's very safe to use, and that vapor is returned to the console through a lumen maintained under vacuum. Main things to consider for the procedure itself. Most of us do AFib ablations requiring transseptal access. So you would do that how you would normally do that in practice. I always use ice for transseptal puncture. Another aspect of this compared to radio frequency ablation is that we do phrenic nerve pacing while we are freezing the right-sided veins. This is because the phrenic nerve does course anterior to the right pulmonary veins. We want to make sure there's no phrenic nerve involvement. So I will place the CS catheter up to the SVC and high output pace at a cycle length of about 1,000 and just watch the diaphragm pace while we're freezing. We also do something called CMAP, where we place electrodes over the diaphragm and we can actually watch the diaphragm pulsing electrical signal while we're freezing. And another thing about the transseptal puncture with cryo is that we prefer a slightly lower puncture point, as well as slightly anterior. And you can see on ice, if you see the left atrial appendage in view, that's probably as anterior as you need to go. The reason for that is that when we want to go to the right-sided veins, it gives you a better angle to clock the sheath and get into the right-sided veins pretty easily. So the way we do cryo balloon is we access the targeted vein with the Achieve catheter. We'll inflate the balloon and press it up against the vein. We inject a small amount of IV contrast to make sure it has a good seal at the antrum of or os of the pulmonary vein. And then we press a button, and that basically allows the balloon to start freezing the tissue. And while we're freezing, we'll usually have a measure of those pulmonary vein signals right at the os of the pulmonary vein, and we'll actually see those signals separate out and then disappear, usually within 30 seconds of freezing. So it is very effective and safe in pulmonary vein isolation. And because of the size of the balloon, we often get surrounding ganglionic plexi, and sometimes we can see that vagal response while freezing. Here's an image of the contrast injection prior to freezing. And this slide was shown earlier, but you can see cryoablation lesions seem to have a cleaner look. The structure of the tissue is still maintained without much thrombus formation compared to a radiofrequency ablation lesion, where you can definitely see some thrombus on this histopathology slide. And here's a voltage map post-ablation, and you can see, there's a pretty good territory, wide area of ablation after PVI with cryo balloon. Hence, I think we get some of that ganglionic plexi with freezing as well. In my practice, most patients are discharged home the same day, usually 2 to 4 hours bed rest. The procedures themselves will take about 1 to 2 hours. And it's pretty reproducible. The time of ablation, the left atrium, is on average about 35 minutes. Depending on the situation, patients can also be monitored overnight in the hospital and discharged the following morning. Sometimes I do that if people have cardiomyopathy and there's some risk of fluid overload. I can diurese them overnight and discharge them the next day. They usually follow up with the physician in 2 to 4 weeks. I personally keep them on anticoagulation for 6 months if they're a low CHA2DS2-VASc score. If there's a loop recorder in place, if there's no loop recorder in place, then I'll order a monitor at 3 months. And at that point, I'll stop their antiarrhythmic drug. And then I wait at the 6-month point to decide if we can come off of the blood thinner or not. Some post-op considerations, and some of this is similar to radiofrequency ablation. You can have pericarditis, some pericardial effusion, shortness of breath due to fluid overload or the pericardial effusion, some palpitations. You could have, develop atypical atrial flutter or recurrence of paroxysmal AFib during the blanking period. You can also have a groin bleed. Sometimes it helps to use ultrasound for IV access in the groin to help prevent any pseudoaneurysm. Then there's lightheadedness and syncope, possibly due to symptomatic bradycardia or pericardial effusion. So in summary, cryoablation therapy is an accepted first-line therapy for atrial fibrillation with potentially less morbidity and mortality compared to antiarrhythmic drug therapy. Early intervention is critical to high success rates with ablation therapy. And risk factor modification is an important part of AFib management as an adjunct to ablation therapy. Any questions? And I will leave it to you.